All right. Thank you so much again, everybody, for making time for our kickoff call today. We are so excited to welcome you to Wave 2 of the Lead Free Ohio Practice Coaching Program. We will be in and out of here in 1 hour. You will be set free for sure by 1 o'clock, if not a little bit earlier. Again, thank you so much for making time for this call. So, a couple of disclosures. The speakers and faculty of this educational activity have no relevant financial relationships with ineligible companies, and we have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is our intent to foster respect, belonging, support, and accountability with regard to the patients we serve. If you have any concerns, comments, or questions, please contact Dr. Kelsey Logan at the contact information listed on this slide. Our objectives for today's session are to outline anticipatory guidance around lead poisoning prevention, describe ODH lead screening and lead testing guidelines, compare different sample collection methods, determine your practice's next steps in increasing your lead screening rates. And now we will take a moment to introduce the program team.
Hi, I'm Rupa Thakur. I am a primary care pediatrician in the Cleveland area, and I serve as medical director for the Lead Free Ohio program with the Ohio AAP. Nick, would you like to introduce yourself next?
Sure. Hi, I'm Nick Newman. I'm the medical director of our environmental health and lead clinic at Cincinnati Children's, and been taking care of kids with lead poisoning and other environmental exposures for over 15 years.
Hi, good afternoon. My name is Joel Davidson. I'm a general pediatrician at Akron Children's Hospital. I co-lead our lead clinic at Akron, and I'm also a physician informaticist and a physician leader experienced in scaling lead screening and intervention across the organization. Glad to be here with all of you today.
My name is Sahavi Salman Reiki. I am the program manager of Lead Free Ohio. I work with the Ohio chapter of the American Academy of Pediatrics. I've been here for a little over 2 years, and I'm your point person for anything that you need throughout this project. You can call, email, send me a text. We want to make this project as easy as possible and want to really support you. So anything you need, I am happy to support.
All right, so thanks for the introductions. So I'm going to have us start with a few things that I want each of you who are participating to stop and think about. I would encourage you to take a few minutes, get a piece of paper or open up a document, take some electronic or physical notes, and actually write down your own practices responses to these three reflection questions. Don't worry, I'm not going to rush through this. We're going to give you some time to do this, but we want to know how you think that you're currently doing around lead screening, and how are you, currently addressing managing elevated blood lead levels. Be honest with yourselves. Be honest with your practices. There's no wrong answer here. It's just kind of trying to get a good baseline for yourselves about where you're starting from. We have some practices that are not screening at all. We have some practices that have been screening and would like to do better. We have some practices that are screening really well and would like to improve how they respond to those different elevated levels, or some other part of the workflow that's related to screening and addressing lead. The second reflection question is, if you could change one thing in your workflow to improve your practice's lead screening or management, what would that be? And then the third question is, what do you want to get out of this program? So what I'm going to do is I'm going to have us all pause for a minute. I'm going to turn it off in terms of stop talking, and we're going to take 3 minutes and have you write down those responses. If you can, please put the answer to your third question, what do you hope to get out of this program, in the chat so that we can all see. If you're not willing to share, that's okay, but it may allow us to get a good idea of what people are hoping to get out of the program. And this is out of the program overall, not just today's introductory kickoff session. All right, so 30 more seconds. I see many responses in the chat, so thank you. But if you want to wrap up your reflections. All right. So, thank you for taking a little bit of time in the beginning of our time together to really think about what's going on in your particular practice. The other comment that I would ask you is, who else do you need to share this with? Is there anybody else that needs to participate in this reflection along with you? So take what you've written or typed, and feel free to keep that, and then share it along your journey as we work together. So I may not have captured a few of the last couple, but in the chat, kind of some themes that I'm recognizing. We have some lab results integration. We have anticipatory guidance, patient education materials, standardizing workflows, handling elevated lead levels, and crosstalk between the Ohio Department of Health. Nick and Rupa, do you guys see any other themes that came out of that from the folks that we have together?
I think you covered it.
Awesome. So you can go to the next slide. So why are we here? Why are we all talking about childhood lead poisoning, exposure of kids to elevated or to this heavy metal of lead? 2% of Ohio's children less than 6 years old have elevated blood lead levels, and 80% of those children who are poisoned by lead are contaminated through lead-based paint in houses that are built before 1978. There are other sources, but still primarily we are talking about homes that have that are older that have lead in the form of paint. The heavy metal of lead has no physiological function and causes irreversible neurocognitive delays and problems in developing children's brains. We do really care mostly about the younger kids because of the impact in brain development at that age. Go to the next slide. So we're going to be talking about 3 different ways to, when we talk about prevention related to exposure of children to lead, we think about it in terms of primary prevention, secondary prevention, and tertiary prevention. So primary prevention are things that we're going to do to work on eliminating the threat of lead exposure for that child. This might be remediation or improvements to contaminated households, making those environments lead safe, or having the child move from a particular environment into another environment that's healthier for them. We're talking in primary prevention or anticipatory guidance topics around cleaning techniques around the house, eliminating occupational hazards that parents may bring home from their workplaces. When we talk about secondary preventions, we're talking about how we can mitigate further harm for those children. This is really where we have screening and testing. We are looking for kids that have been exposed to lead. When we identify that those kids have an elevated level, then we're talking about things that we can do to mitigate further harm to that child. But by definition, those situations are really secondary prevention. And then last, tertiary interventions are things where we can manage those outcomes. And really in that realm, the evidence points to directing kids towards early intervention services, getting them the support that they need to, despite this irreversible damage that's been done related to the environmental exposure of lead, getting them into some services that are going to help improve their future being in services. Okay, we can go to the next slide. Go ahead and highlight. Really, I'm glad that some folks brought up that they would like to improve their anticipatory guidance. That's one of the things that they're hoping to encounter. That is certainly something that your practice may work on with your coach around improving, making sure that families are understanding what's going on early in that child's development, at the right time in that child's development, so that we're beginning to talk about those things for the right patients. And what things do we talk about, and how do we talk about them, and which things are the most valuable. And we're going to share some tools around that we've prepared that you have access to by participating in this program. So in talking about anticipatory guidance, we really want to recommend that practices start talking to 6-month-olds. Why 6-month-olds? Maybe not even, there's testing is not even recommended until 12 months old. We're testing at 12 months old. Why are you asking me to start to talk about this at 6-month-olds? 6-month-old babies are starting to reach for objects, transfer those objects, putting those objects into their mouth. They're beginning to crawl around surfaces that often have lead dust. As lead gets, as surfaces of friction throughout a household get exposed, those friction events like opening and closing a door or a window or moving around in a space will create dust, and that dust is settling in those spaces, and those children are beginning to crawl. We also know that this is also a great time to begin to talk about that as their exposure increases in that 9 to 12 to 18, 24 month age range. So we talked a little bit about common sources of lead. You can help families identify that. Is there any peeling or chipping paint in your home? Do you have older windows? Is there spatially a window close to or at the child's level where they're like chewing on any surfaces that might be older or painted? Are there leaks of water around the house that are disrupting layers of surfaces where lead is existing, that you can identify that might be a concern? Some of our patients that have come to us may describe an upper story bathroom that's been leaking, and the drywall is disrupted, and that happens to be over the dining room table. Like, all of those are factors. By talking to the family about what their environment looks like, and if any of those risks are present, you can start to talk about how to mitigate some of those risks. Talk about wet wipe mopping once a week. We talk about wiping all surfaces down regularly, along with just kind of spatially which surfaces is the child most likely to be exposed to. Are they washing their hands before a meal? Are you washing their hands off before they're putting their hands into their mouths? And last, we're going to talk to families about making sure that their diets are high in 3 things, especially for lead. Making sure that they're getting they have a good calcium source, that they have a good sources of iron, and that they have a good level of vitamin C. All of those things are not going to eliminate lead. They're not going to chelate lead out of the body, but a child that has a healthy diet in these things is less likely to seek out sources of lead in their environment. Okay, go to that. One of the tools that we've developed, Rupa and Dr. Tucker and Dr. Newman have put together an awesome board book, which is age appropriate at this 6 to 24 month age, that touches on topics around lead. I love integrating books into my care, where you can have a child explore something that's colorful, something that's engaging. This book has a lot of representations of very diverse cultures. But you can use the book as a teaching tool to talk about the various exposures and different things that families can do around lead by using this board book. Each of you in your practices, by participating in this program, will be getting 120 books. As you continue to be engaged with the program, there may be some opportunities towards the end of this program for you to get even more of those books, if that's something that you've successfully been able to incorporate into your anticipatory guidance. The next resource that we have to share with you are rack cards. These are things that are about a third of a page each, with a front and a back, and we've kind of shown you what the current rack card looks like here. It's visually appealing while also incorporating different elements of anticipatory guidance around lead. So where the first front kind of shows the whole state of Ohio, which county is at higher risk. The reality is that each one of our 88 counties in Ohio have some pockets of high risk exposure to lead because it's really an older housing problem. So really no one's exempt from that, but there are areas that are experiencing a little bit higher levels of high lead. This reminds patients that there's no level of lead that is safe, that children are the people that we care about the most, and that it impacts learning and behavior. And then at the bottom, we kind of talk about paint and paint dust. Additional sources include spices and traditional medicines. Certain occupations like construction, smelting, firearm use, and pottery can be high risk employment areas or high risk hobbies. Lead lines is called out in the last line there. And water can be a source of exposure for families. If they're worried about it and their families are expressing that as a concern, we do recommend that they run the water first time in the day for 1 to 2 minutes, just to kind of flush those lines out. And then after that, the water is safe. The back side of the card talks a little bit more about available resources and specifically what children and families can do with elevated leads. So any child with lead does need follow-up. We're going to be talking about some of that in our testing section in just a few minutes. Lead increases those risks of learning and behavior problems. These are sometimes more executive functioning skills that we don't always see until the child's in the early school ages and the early elementary school ages, for example. It calls out the healthy diet. I'm not going to repeat those things because we just talked about them. And then that all kids, it kind of calls out also, and maybe you all don't know this, but all kids under the age of 3 with a documented elevated blood level over 5, over 3.5, are eligible for early intervention services with a referral. And if you need help, there's the phone number around potential sources with the SCHIP program. And then the 2 QR codes that we have direct you to some of the information that we've developed as a team to help you address lead. And so you can get this information on those 2 QR codes. At this point, I'm going to turn things over to Dr. Newman, who's going to talk a little bit more about what's available in our toolkit and how to address some of those elevated lead levels.
Hi, everybody. Nice to meet all of you virtually, and thanks for being part of our learning collaborative here. So the toolkit has, the idea is to provide some education to the healthcare providers and understand about lead. I mean, I think we've been, I don't know, I've been in practice a long time. We've been talking about lead since for decades. And although we all thought this would go away, it hasn't gone away. And, at first I would, let me see, I don't know if you can, I don't have a pointer here, but like, if you look on the right side, like where it talks about, signs and symptoms of lead exposure, I'll tell you right now, like even someone who runs a referral clinic for kids with lead poisoning, even then it's very unusual to see any symptoms related to lead. And I think that's one of the difficulties in terms of, as a physician, trying to get families engaged around it. And I often think of lead almost as like high blood pressure. My wife is a family physician, and hypertension is like essential hypertension is one of the most common diagnoses she has to deal with, and one of the most common diagnoses that her patients ignore, kind of at their peril, right? So like the everything's fine until like someone has a stroke. And I think the same thing like with lead, like you don't see any symptoms, everyone seems fine, but everything's fine and good until like, oh gosh, Timmy is in 3rd grade now and he's acting up and he's having trouble with reading and all this other stuff. And this was the kid who had a really high lead level when he was like, between the age of like 2 and 4, right? And he looked fine at 2 and 4 and no one, was thinking anything. So I think that's how I think about it. And maybe that's a helpful way for like all of you to think about it too, that this is a problem that, doesn't necessarily manifest all of its symptoms until much, much later. So and so now we'll go to the left side. So there's a in a lot of offices, there is not an option to get venous blood levels or venous blood of any kind. And so capillary testing is done, right? And I think like the thing to think about with capillary testing is this is not meant to be like the gold standard. Like this is very similar to you check an Accu-Check in the hospital for glucose. You have to go and confirm that with like a higher reliability test. And so the recommendations is that if the capillary level is less than 3.5, it's not required that the venous level be rechecked. But if there's any detectable amount of lead, I think that ought to like just raise your your ears should like perk up just a little bit, because the average lead level for children in the United States, the geometric mean lead level, is less than 1. And so if you have someone that is detecting anything, they're already like in at least the top 50th percentile. And just to give you an idea, 3.5 is the 97.5th percentile. So there's only about 2.5% of kids who have a lead level over that amount. And so, so as you start to look at this, you realize that, as the lead level is higher, we need to check this, much sooner. And I can tell you of a recent case we've had to deal with where the capillary level, read in the 20 to 44 range, but the venous level came back like significantly higher than that. And so, and the child needed treatment. So, like, I think the capillary level has there's a lot of issues with it. It's a good screening test, and I almost think of it as like a positive or a negative, right? Not so much like the quantitative level is not, you can't really take that to the bank like you can a venous level. So you can see, we don't want these things to just be left, because if you're detecting lead, there's a good what you want to make sure is that it's not going up or it's not higher than what the capillary level says. So can I have the next slide, please? So ODH has created a screening questionnaire. So like, and the point of this is to try to make sure that we don't miss anyone who could possibly be exposed to lead. And really, if you look at the first 2 questions, those are the things that trigger like the legal requirement to test for lead. So if the child is on Medicaid or lives in a high-risk zip code, and the form that ODH has a list of the zip codes. Now, I can tell you down here in Cincinnati, we just decided to test everybody because almost every single zip code of our like primary and secondary service areas are high risk. And so like to go through like that for the volume of kids that we see, it wasn't worth it to us. But each practice needs to decide, but this is at least the minimum that you should do. And the next questions are about the age of the home. So like basically lead paint was banned in 1978. They started phasing it out in 1950, so there were voluntary controls. So the 2 questions about regularly visiting a home or child care facility or that is older, I think we also have to understand that a lot of people may not know the age of their children's child care facility. And so if that's an unknown, then that means a yes. So like these questions are, if it's a no, then that's potentially reassuring. But I can tell you, I've had a family several years ago, and I asked the mom like how old her house was, and she said, well, it's old, but not that old, like maybe 1960. Now I asked her that knowing full well the age of the home because we had already looked it up. And the home that she thought was built in 1960 was built in 1821. So I think you have to. It's not that she was trying to tell me something wrong. It was just that she didn't really know and was just kind of giving me her best guess. So, like, once again, if there's any question about the age of the home, assume that it's older because, over 2/3 of the housing in Ohio was built before 1978. Um, and then if there are other children who did have lead poisoning, it's really recommended to check the other kids who are in the home or other kids that this child plays with. Um, and then we get into occupational exposures. And the most common one that we see here, we had one of my uh, students working on a small study here. But the most common occupation that we run into here that could be lead, a lead risk occupation is construction. And particularly people who do any kind of demolition or renovation because they're renovating old places and the dust gets on them and they bring it home. And it's not uncommon for kids to have a lead level in the 20s from dad's clothing just shedding dust in the house when the kids play with them, when they come home. And then, I'll be honest. Like it asks about, do you live near an active or former lead smelter, battery recycling plant, or other industry? The truth is like a lot of people don't know, right? I mean, that's the nature of the fence line. Sometimes you don't know what's going on the other side of the fence. So if there's any question, I hate to say, just like assume that it's positive because we're already not screening. We're not testing. We're not getting blood lead levels on like around 50% of the kids who probably should be tested. So there's plenty of room for improvement. Can I have the next slide? And so basically the first section here, like test at 12 and 24 months if. So that is you must, because that's what the state law requires. So if the child's insured by Medicaid, if they live in a high risk zip code, or any of the questions are yes or don't know on the questionnaire. It's recommend, and then if the child has never been tested, they definitely need to be tested between 3 and 6. And it's also, so it's not like the law, but it's definitely recommended to test the kids yearly if the risk factors still exist. And I would just say as a clinician, if you have some concern, like we get a lot of patients referred to us from other services within our hospital, GI or developmental peds or HEMONC or whatever, because they have a kid with pica. They're not checking the questionnaire. They're saying, you have a lot of pica. We're gonna check your lead level, just make sure you don't get exposed to lead. So, I think if having even if you end up with a no to some of these questions, or you're like, well, I don't know if I should test or not. If there's some clinical reason to test, go right ahead. Like these are like kind of minimum testing guidelines. This is not like, oh, don't do this if the answer is no, right? So, and then capillary testing, including this point of care testing as well, can be used, but venous confirmation is required for lead levels that are above the blood lead reference value, which is 3.5. So the next slide, and I think we move on to Dr. Takor now.
We have a few more for you, Nick, I think. I'm happy to take them, but
oh, I'm sorry. Yeah, I miscounted. So some places the EHR will have lead screening built into their like health maintenance reminder system. If that's possible at your place, that's probably one of the easiest ways to make sure that stuff gets done, because I mean, everybody knows how difficult it can be to navigate in the EHR. And if the thing is like helping direct you to something, that definitely makes it easier, right? Next slide, please. And so there are a bunch of different like ways that you can collect the samples, right? So and we try to go through this like quickly and not read the whole thing to you because you can all read yourselves, right? So you have basically like three basic approaches for capillary testing. There is a point of care machine. There are you can use microtainer tubes with like either with a scooper or with a tiny capillary tube in it, or filter paper. Now, the only device right now is the LeadCare device, a point of care device. There is a significant upfront cost, and then there is also a fee that has to be paid to the state every year as like a licensing fee that helps to support the program that's used to follow up with all the kids. The good part is that you can get the result right away, like within a couple minutes. The problem is that there have been some problems over the years with recalls, and that had to do with like some technical issues related to reagents and tubes and like all kinds of stuff that as a clinician you're not going to necessarily know about. It is a CLIA wave test. The microtainer tubes are actually pretty it can be a little bit time consuming to collect the blood. They use the same machines that they use for like venous processing. So like inductively coupled plasma mass spectrometry or a graphite furnace atomic absorption of spectrometry. So they're accurate. The problem is it's like, all that squeezing and all that stuff. There's a lot of crying. There's a lot of screaming. It's a lot of clotting. There's a lot of quantity insufficient. So that can be a problem. We tried that in my old practice back in Michigan. It was a challenge. It was really a challenge. The filter paper testing, this is nice because both like MedTime, well, these are, we're not endorsing any of these companies. So, you can there are commercial services that do this. Some of the local children's hospitals and other labs are also doing this. What's nice is that you don't need a huge volume. It's similar to what you need for any kind of blood spot. And it's quite stable. Like, you get it on there. Like, I know our hospital has a courier that goes out like once a week to practices and picks the stuff up. There can be some technical issues. Like it's more operator dependent. I'm sorry, whoever's collecting the blood, like it needs to be like evenly spread across. You need to, so there's some training that's involved in that. And whoever's processing it needs to have special equipment to be able to do that, but that's not your problem, right? And then finally, venous testing. So like if you draw blood in your office, like we do here with, venous blood, that can be, quite time consuming, but it is very accurate. Potentially you could run other things off of that sample as well. It's not like people don't like it, because like, oh my God, does my kid have to actually get a poke? It's like, yes. And like, well, couldn't they just do the finger stick? I'm like, there's actually, as we all know, fewer nerve endings on this part of your arm than down in your finger, but like, that's a whole other issue. And then if you don't have phlebotomy in your office, then, that requires a trip to the lab, and that's where you lose a lot of people. And the reason that our primary care is even tests, does venous sampling is that we would lose the families between the clinic and the lab across the hall from the clinic. So, while you have them, the idea is to try to get people while they're there, and, meet them where they're at. So, I don't know. Do I have more slides?
Nope, nope. I'll take
Are you
over from
sure?
here.
Okay. All right.
Yep,
Sorry. I miscounted everybody.
you're fine. So I'll echo my colleagues. Thank you so much for joining us today. We're so excited to have you. I'll give you a brief overview of the practice coaching program we're offering this year. So as you might know, we've led quality improvement collaboratives in the past that helped practices improve their lead screening and follow-up rates using more of a formal QI design. This involved multiple calls and meetings that convened a smaller cohort of maybe just 5 to 12 practices, required a lot of data collection, so a little resource intensive, and resulted in high quality outcome tracking and measurable changes in practice. So it was effective. We're also known for educational webinars, which typically utilize more of a didactic, case-based, or Q&A format to engage and educate a large group of practices across the state in a single meeting. Data collection in those webinars is typically very minimal, but really aimed at tracking planned change in a practice based on some of the knowledge gained during that session. So with our practice coaching program, we're trying to combine the best of both worlds. So in this medium-sized cohort of 20 to 50 practices, you will receive individual guidance based on improving your lead screening and testing rates through multiple calls and meetings. So with only moderate data collection, which I'll show you here in a moment, you will still achieve high quality outcome tracking and measurable, hopefully sustainable change in practice. Next slide. So to do this effectively, we've outlined some of the activities required for program participation here. You're here today at our kickoff training, so you can already check off the first activity from this list. Next up will be baseline data collection, which we'll talk about in a moment. After that, you can expect individual coaching sessions and open office hours to help drive your practice's quality improvement initiative. And then we're going to wrap up the program with endpoint data collection and an exit interview. And if you complete all of these activities, including attending at least one of those office hours, which are scheduled on Thursday mornings, your practice will receive a $400 stipend. Next slide. So we'll talk a little bit more about the data collection piece. You'll first be asked what testing method you currently use, because this will affect what data will be useful for your quality improvement initiative. So you can mark venous collection only, capillary screen with venous confirmation, or that you don't know yet. Next slide. And if you marked venous collection only, your next set of questions will look like this. You'll be asked to share how many 12-month well child visits your practice completed in August to understand our denominator. Of those, how many had a lead test ordered? And then of those, how many had a lead test actually resulted in their chart? So the test was completed. These values will help us understand if your quality improvement effort should be focused on educating providers to order the test when it's indicated versus actually getting patients to get the test done, either through trying a different collection method or maybe brainstorming ways to get more of those kids to the lab effectively. Next slide. If you mark capillary screening with venous confirmation, we'll ask you to clarify the specific capillary sampling method that you use. And then if you hit next, Suhavi, we'll go through the same set of questions that our venous test friends answered. How many well visits did you complete in August? How many of those had a capillary lead test ordered? How many of those have a lead test resulted in their chart indicating that the test was actually completed? And then after that, we want to look at whether your follow-up of elevated capillary samples is optimized or not. So you'll be asked how many of the results from question 3 were elevated, were over 3.5, warranting that venous confirmation step. Next, how many of those that warranted it had a venous test ordered? And finally, how many of those that had the test ordered actually completed the test and have a result documented in the chart? Again, the data collected at each level of questioning will help us pinpoint where your quality improvement efforts could be most fruitful. Next slide. In 2024, in our first round of practice coaching, our cohort saw a pretty remarkable increase in their overall lead testing ordering rate from an average of 77% in their baseline data to over 85% when the program ended. Our first cohort also reported that of the lead tests that they did order, only 53% were actually being completed in their baseline data. And this increased by almost 10% by the end of our program. So we're hoping that you might achieve similar results. Maybe next slide. Yeah, there we go. So that's the completed out of the well child visit. So your immediate tasks are to fill out your baseline data collection forms, as well as to start thinking about getting some buy-in for your quality improvement initiative. So I hope you'll take a moment to think about who the stakeholders are that you need to engage. Your colleagues, your nurses, your leadership. Do you already have connections with those folks, or do you need introductions? And who could provide those introductions if you do need them? And how will you start that conversation? Really getting into the nitty-gritty of what you're going to do, setting some SMART goals for yourself. Are you going to email? Are you going to make a phone call? Are you going to set up a meeting? When will you do that? By when will you do it? And when you have a chance to connect with those stakeholders, how are you going to get them as excited about this project as you are? How will you maybe determine what's important to them and what would motivate them to engage in this work? Where does your ask align with their goals or values? How could you leverage that commonality to get them on board? I'd also love for you to start planning for our upcoming coaching sessions. Think about who you want to be present at that session. How can you ensure that those people you'd like to attend are able to be there? So my recommendation is to have as many members of the team present, including maybe front desk staff, medical assistants, nurses, care coordinators, patient navigators, whoever you have who you think might be engaged and involved, and maybe help come up with some solutions for you. Sometimes really innovative ideas come from the discussion we have when we bring together all the people that might touch a family during their visit with you. And sometimes I've been surprised by what folks on the team are willing to contribute to our quality improvement efforts when they understand what that common goal is and feel like their voice has been heard and they're contributing. Next slide. So I'll end here with another reminder of the practice coaching program requirements this year. You're already at the kickoff call here today. You're going to complete your baseline data collection prior to your first coaching session. Hopefully we can get that done today. I know Suhavi is really looking forward to receiving that from you. So baseline data collection as soon as possible. Coaching session will come up next. You will attend at least one office hour, but please know that you're welcome to attend them all if you want to. Upon program completion, you'll submit your endpoint data and conduct an exit interview with our team. And when you do those few things, you'll earn a $400 stipend for your practice to put toward improving care for your patients in any way that you see fit.
Thank you so much to our medical leadership team for the wonderful presentation. We're going to pause for a moment and get a couple of things done. If you scan this QR code, and I'll pop the link in the chat as soon as I'm done talking, we're going to fill out a form that will allow you to indicate your availability on average for your coaching session. So you'll just have the days of the week, Monday through Friday, morning and afternoon. And then you'll also be able to order rack cards for the program. And we'll take a moment to do that. And then if I could just be super clear in that double checking your address when you put it in the form would be great. Make sure to include a suite number if there is one. We will be shipping these to you as part of the program, but we want to make sure that they get where they're supposed to go and don't get lost in UPS land. So just double check the address when you're filling out the form, and I'll pop the link in the chat in case anybody cannot scan that QR code. Just one moment. And then for that availability, we'll work with you. You know, if you say you're available Monday morning and the morning that we suggest you're not available, we'll find another one. This is just to get that conversation started. And we'll take a few minutes to do that. I get emails when the forms are completed, so I'll know once they start trickling in. I'll also be sending all of these links and forms and the slides, of course, when we're done with the call today. So no need to rush through. You can always come back. I can hear my computer email dinging with the forms coming through. So thank you so much. Next, I want to make you aware of what we call our lead hub site. It is lead.ohioaap.org. Should be fairly easy to remember. And of course, it'll be in that email that I'm going to send in a couple of minutes here. This is really where you're going to find everything that you need to access for the program. This is where the baseline data and endpoint data forms will live. You'll find my contact information, all of the resources that we have for the program, just the digital version, of course, the Zoom links for office hours, all of the things that you need. So I just want to make sure that you have access to that site. You could always bookmark it while you're in the program. And then if you no longer need it, feel free to just remove it from your favorites tab when we're done. And I'll pop that link in the chat as well. Okay, and we're going to take the last couple minutes here for some Q&A. And I did just get a question in the chat about Rocking Horse. So since there are quite a few people from Rocking Horse on the call, I'll just answer this out loud. Do we know how many rat cards? There are multiple people from Rocking Horse on here, so I'm not sure if all of us should complete that. I would have one person from each Rocking Horse location complete the form, and I can kind of look through and work with Lisa and make sure that everybody's address is on the form because I only have the Limestone Street address as of now. So fill out the form however you see fit, and I will go in and thanks, Dr. Beasley. I will go in and make sure it all makes sense. And, one location isn't getting thousands of rat cards and another's getting none. So, okay, let's jump into Q&A.
I have a question. Hello. Thank you so much for the great presentation. I was just wondering that if we could have some pamphlets for educating the families on the nutrition or the diet and something that'll be super helpful for them to take home because that's what they struggle with, and especially with those the levels, just let's say 8, 9, or 5, 6, we have to just educate about the diet and hand washing and all that. So that diet thing is, I think, will be super helpful.
We do have some information on our toolkit that might be helpful, but we can work on creating if there's like a handout or a rat card that you think would be helpful just to hand to them or to
Yeah,
facilitate that conversation, we can work on that.
absolutely. That visual thing really helps.
I know
Yeah,
the Ohio Department of Health has one for preventing childhood lead poisoning that you can print, but it's only in English. And we have a lot of Haitian Creole and Spanish speaking patients.
Okay, thank you.
yeah, it's US EPA. I don't know if they still are making their nutritional handout, and we can see if that's still around too. I mean, a lot of this stuff, a lot of the like federal printing and stuff is kind of like dropped off because they had they didn't have like Haitian Creole, but I know they had Spanish and at least a couple other languages the EPA used to have. So we could look into that. The um, and I guess just like one thing, like I think parents often take away that like the wrong impression that somehow or another, like if we give the kid a multivitamin or if we give the kids a good diet, like the lead level, like that will fix the lead. And I think like just to understand that like the lead will be eliminated from the body very, very slowly because of the like the half-life in the bone being like probably over a decade. The blood level in the the half-life in the blood is like a month. Um, so it could take a long time for the blood level to come down, but like really the thing that often intersects with children with elevated blood lead levels is that the food insecurity and often like a poor diet or poor choices around diet or just poor knowledge about what a normal diet should be for a young child. And so it's often helpful to use lead as kind of an organizing principle to get the to try to promote some of this healthy eating. So like I think it's worthwhile, but I know people come in and like, well, I'm feeding them the right thing and I'm giving them a vitamin, but their blood level isn't coming down. It's like, well, the house has to be abated and we're waiting for the contractor to do that. Like that's really that's what's going to solve the exposure problem. So it looks like Dr. Beasley solved the whole problem. And I don't know, we have I don't know if they can speak or not, but I think there's at least one person from ODH who's on the call who might be able to help us if you're looking for something from the ODH system.
Hey, Nick, I appreciate the shout out, but the pamphlet that Dr. Beasley just posted is our information, and that's the extent of what we have available publicly.
Okay, awesome. Yeah, thank you.
Yeah, so I'll take that comment and the next one in the chat around electronic health record integration and recommendations. The comment in the chat from the was that our system doesn't have a very good record of health maintenance, and that's not uncommon. And I would, the interventions are really fairly specific to your organization and to your institution and how changes can operate. But to Dr. Kumar's point about available resources, diet is one of those things. Taking the information that is in the toolkit, we've kind of designed it intentionally. We've spent a lot of time on the verbiage and the wording there. And there is even a section around electronic health record integration. So you can feel free to take some of those things and put those into your own system, if that's feasible for you, if that works in terms of a way to communicate with your patients. I'm always, as a clinician, a little bit hesitant to just using a handout, meaning handout alone, if you hand it to someone, it's not going to be very effective. But if you can use it as a tool to engage your family and really provide some real teaching with some teach back, I think that's the ideal situation. I never have an expectation that if I create the perfect handout and then give it to them that will be the holy grail, which it's not. But that's another reason why that there's not like a one-stop shop, one handout solution to this problem. On the what do I do if my electronic health record system does not have a good way to track this? Number one is this program, we're going to go through kind of some simple data analysis. Again, not terribly complex, but let's start, take a look at where are you currently? Where are you in the last week? Where are you, and how could we, utilize some other tools, to remind you that that's the right thing at the right time for the right patient. And we can also help you work when you get into this specific coaching. If that's something that is a challenge for your clinic, we can talk about how you can mobilize the stakeholders within your organization to accomplish that goal. So it's okay is the take-home message from that, and we're here to help you to navigate to make that better than what it is right now.
Thank you for those wonderful answers. Any other questions that we have right now? And throughout the program, you are, of course, always welcome to send me an email with any questions, and I'll be happy to pass those along to our medical leadership team. And as Dr. Newman noted, we are close with our partners at the State Department of Health. John Belt is a wealth of knowledge and has been working with ODH for many years, and his team is great as well. So we're happy to open up lines of communication and really support you however you need, be it a one-off question or you're considering getting the LeadCare 2 machine. We'd be happy to facilitate with whatever we can. Hearing no other questions at this time, I want to share how you can claim your CME and MOC credit for the session. So if you scan the QR code, which I will also send the link in my follow-up email, you're going to take the outcome survey, and please go ahead and take the survey even if you don't need credit. We like to see how people are receiving our education and if they enjoy the rigor of our programming. And then check your email for a certificate within 10 days of completing the survey. If you have any concerns, please feel free to send me an email. And this is my contact information here. That's our office line there on the screen. And then that's my email. If you have any questions, concerns, comments, ideas, anything you want to share, more than happy to support throughout this project. Again, like I said in the beginning of our conversation today, our goal is to make this project as seamless as possible. We are here to help you with whatever you may need, big or small. We want this to really feel like a natural extension of the work that you're already doing, which will make it easier to be a sustainable change long term. So if you have any ideas for how we can improve or be a better support and partner to you, please don't hesitate to reach out at any time. And that concludes our kickoff call. Thank you so much for making time for the session today. We're really excited to work with you all.
Thank you.
So long.
Bye.